Good afternoon, ladies and gentlemen, and thanks for waiting. All lines have been placed on listen-only mode, and the floor will be open for your questions and comments following the presentation. Without further ado, it is my pleasure to turn the floor over to your host, Ms. Linda Harris. Ms. Harris, the floor is yours.
Thank you, Wes. Good afternoon, everyone, and welcome to our webinar, Using the MDS to Measure Flu and Pneumonia Vaccine Outcomes. My name is Linda Harris. I'm an improvement consultant with VHQC. I'm joined today by Teresa Mandela, who's also an improvement consultant with VHQC, and Sheila McLean, program director with VHQC. Today's session will be recorded, and the recording will be emailed to you. It will also be available on VHQC's website within around 7 days. During today's webinar, I encourage you to commit to being attentive and engaged, open, collaborative, and actionable. Avoid multitasking and set yourself on an email to the side. We want this to be an interactive webinar, and we ask that you participate by using the chat feature of the webinar by clicking on the chat icon in the upper right-hand corner of your screen. It's in the middle between participants and media viewers. You may enter a question or comment into the chat for the presenter, and we will facilitate her response. We would also greatly appreciate your feedback to assist us with future planning. Please take a minute at the end of the presentation to answer the evaluation questions that will appear on the right-hand side of your screen. VHQC is a private, nonprofit healthcare consulting company that has served as the QIO for the state of Virginia for over 30 years. Currently, we serve as the Quality Innovation Network Quality Improvement Organization, the QIN-QIO, from Maryland and Virginia. The overall goals of the Nursing Home Improvement Network are to decrease antipsychotic medication use, decrease potentially avoidable hospitalizations, increase mobility of long-stay residents, and achieve a score of 6 or less on the National Nursing Home Composite Measure. Additionally, facilities will have the opportunity to choose from other QI topics, such as systems level improvement, which includes staff stability and consistent assignment, decreasing health-associated infections and other healthcare acquired conditions, including pressure ulcers, urinary tract infections, and C. diff. The NHIN online community provides a 24/7 location for you to engage with other nursing home providers in the Nursing Home Improvement Network, with VHQC improvement consultants, our expert faculty, and peer mentors. We encourage you to join and take advantage of this additional resource offered by VHQC. The VHQC consultant contact information will be presented on the slide at the end of the presentation. Please contact us if you have any questions about this network or are interested in becoming a participating provider. Now, it is my pleasure to present the speaker for today, Judy Wilhite-Grant. Welcome, Judy. I will turn the webinar over to you.
Thank you very much, Linda. I'm delighted to be here. I cannot see the slides turning.
Judy, we are seeing them turn. Emily, could you address Judy's problem? We are on the slide with your picture at the moment. If you want to just advance, we're seeing them advance.
Okay.
We're on a...
Should I log out and log back in? I cannot see the slides advance.
Okay. Emily, at WebEx? Okay. Just one moment, everyone. Thank you for your patience. We're just having some technical difficulties, and we'll just be right back with you.
I can see them advance now.
Okay, excellent.
Okay.
Okay, thank you so much, Judy. Go right ahead.
All right. So you can see your objective there. We're going to talk about the coding rules for coding both influenza and pneumovax vaccine on the MDS. Then we're going to take a deeper dive into exactly how these long-spaced measures are calculated. These are the ones that are used in the calculations that VHQC was just talking about. Then we're going to talk about challenges and best practices in monitoring and delivering the vaccines in nursing facilities in the United States. So the influenza vaccination is covered in Section O0250 on the MDS, and it's just a little box. You have a picture of that on your screen now. And we're going to discuss each of the elements of this box and what correct coding is for them. So in that section of the RAI manual, like in all the sections, it has the reason for the item on the MDS. And here's what the manual says about that. Our residents, older adults, and personnel with underlying health problems are at increased risk for complications from flu and more likely to require hospitalization. An institutional influenza A outbreak can result in up to 60% of the population becoming ill, with 25% of those affected developing complications severe enough to result in hospitalization or death. I have been a long-term care nurse long enough to see my residents in situations where the influenza virus flew through the nursing facility. It will break your heart to see the residents that are severely disabled and that die, to see staff children, to see the effects on the community of a flu outbreak. Fortunately, we don't hear of that near as much now as we used to, but that's because of very conscious dedication to making sure the vaccinations are given appropriately. So, under planning for care, the RAI manual says flu vaccines have been proven effective in preventing hospitalizations. They could cause serious side effects, but the risk of serious harm or death is extremely small. The vaccine is inactivated. You cannot get flu from the vaccine. I'm from the generation of nurses that sometimes don't believe that, because when I started getting my vaccines in 1980, that wasn't the case. But you cannot get the flu from the vaccine. This next one is very important. People who are moderately or severely ill should usually wait until they recover before getting the vaccine. Notice it doesn't say should not get the vaccine. And we're going to talk about best practices to ensure that vaccination status is not a one-shot deal every October, but it is part of the life of the nursing home during flu season. People with mild illnesses can usually get the vaccine, and this is up to a conscious decision made by a physician or non-physician practitioner after examining the resident. So our physician and non-physician practitioners have to have a robust involvement in vaccination status of our residents, and we have to be the people on the front lines reading the charts, letting them know who needs one-on-one assessments of the appropriateness to receive the vaccinations. The flu vaccine can be given at the same time as other vaccines, including the pneumococcal vaccine. So these are the steps for assessment for the flu vaccine. You review the medical record to determine whether the flu vaccine was received in the facility for this year's influenza vaccination season. If vaccination status is unknown, proceed to the next step. Let me stop here a minute. About a year ago, they changed this block on the MDS. It used to say this year's influenza season. Now it says this year's influenza vaccination season. And that's important. The current standard of practice is to deliver the vaccines for this year's season as soon as the vaccine is available to be given, even if you get it before flu vaccine. And most years, they do start arriving in pharmacies before the flu season starts. It says if the vaccination status is unknown at this point, proceed to the next step. Ask the resident if it was received outside the facility for this year's flu vaccination season. If vaccination status is still unknown, proceed to the next step. If the resident can't answer, ask their RP, legal guardian, or physician. If the influenza vaccination is still unknown, proceed to the next step. If you cannot determine their status, they can't talk, and there's nobody to ask, and the physician doesn't know, administer the influenza vaccine according to standards of clinical practice. So a couple of things here. There's absolutely no reason to get to the end of this protocol and put -unknown in the question, has the resident received an influenza vaccination in this facility for this year's flu season? There's no clinical reason why we can't determine the answer to that question. And according to these steps for assessment, if we don't know whether they got the vaccine or not, we are to give the vaccine. The risks of getting the vaccine are so much smaller than the risks of not getting it. Now, that's, of course, unless the physician has said they're medically contraindicated. And it's real important for the facility to have a central place in the clinical record, decide where it is, whether it's electronic or on paper, where vaccines are documented. Because if you determine that the resident was vaccinated outside the facility because of an interview you did with a resident or whoever can speak for them or the physician, it's important to document that in the clinical record. I believe that I am having problems with advancing the slides again, but let's see how this goes. Okay, so these are the coding tips and special populations, and this is important for new MDS coordinators because you just kind of have to remember this as the resident gets their series of PPS assessments or OBRA assessments throughout the year, because this question comes up on all of them, whether you're in flu season or not. So once the flu vaccine is administered to a resident for the current influenza season, the value is carried forward until the new influenza season begins. So when they have a quarterly in July, you answer the question as it applied to the flu season that is now behind you that finished in the spring of that year. Flu can occur anytime, the manual says, but most influenza occurs from October through May. However, residents should be immunized as soon as the vaccine becomes available and continue until influenza is no longer circulating in your geographic area. So, vaccine becoming available does not mean when we ordered it from the pharmacy, when our physician likes to give it. It means when the pharmacy has it for you to administer. So it's real important to stay in contact with your consultant pharmacist and make sure they let you know when they have the flu vaccine so they can start shipping it so you can start giving it. Information about the current influenza season is on the CDC website or your local health department's website. So, the first question is, did the resident receive the influenza vaccine in this facility for this year's vaccination season? The manual says it may be prior to October 1st. The vaccine is usually available in September and some years August. So this is important. If you gave the vaccine for this year's flu season, after the vaccine became available but before the official flu season, the answer to that question is yes. They got it for this year's influenza vaccination season. Okay, now coding to the next one, the pneumococcal vaccine, which is 00300. So this is much shorter because this is not a seasonal vaccine. Is the resident's pneumococcal vaccine up to date, yes or no? And if not, you state the reason why it has not been received, and we're going to talk about those reasons. So the manual says that pneumococcal disease accounts for more deaths than any other vaccine-preventable bacterial disease. Now, let's just think about that for a second. More deaths than any other vaccine-preventable bacterial disease. Fatality rates for pneumococcal bacteremia are approximately 20%, but they can be as high as 60% in the elderly. The manual says if a resident has a moderate to severe acute illness, he or she should not be vaccinated until the condition improves. However, someone with a minor illness, for example, a cold, should be vaccinated since minor illnesses are not a contraindication to receiving the vaccine. And again, the physician is who determines that. If your physician needs guidance on current standards of practice, the Centers for Disease Control, CDC.gov, has all kinds of information for prescribers, for providers, for the community. We'll show you that website in a minute. So for coding the Pneumovax on the MDS, it says, number 1, determines whether or not they should receive the vaccine. All adults 65 years of age or older should receive the pneumococcal vaccine. Certain people should be vaccinated before the age of 65 unless immunocompromised. Those with HIV should receive the vaccine. If vaccination status is unknown, or the resident or their family is uncertain whether or not the vaccine was received, the resident should be vaccinated. Now, that is unless medically contraindicated. Okay, so the standard is once in a lifetime with some exception. Revaccination is recommended for those at high risk for serious infection and those likely to have rapid decline in pneumococcal antibody levels. And it says, for example, so this is not an all-inclusive list, but these are some examples of people that might have rapid decline in the antibodies: asplenia, sickle cell, HIV/AIDS, many cancers, chronic renal failure, nephrotic syndrome, conditions associated with immunosuppression. And people 65 years or older should get a second dose if they received the first dose more than 5 years earlier and were less than 65 at the time of the first dose. All of this is in the coding instructions in the RAI manual, and it mirrors almost exactly what the CDC says in their clinical guidelines. So they include an algorithm for exactly what we just went over for how to determine whether or not a person needs a pneumovax, or whether they need a second one. So here are the steps for assessment for the pneumovax. Review the medical record for pneumovax status. If vaccine status is unknown, proceed to the next step. Ask the resident if the pneumovax was received. If they don't know, proceed to the next step. If they can't answer, ask whoever can speak for them or their physician. If the vaccination status is unknown, proceed to the next step. And I suspect you can guess what's coming based on what we said so far. If you don't know if they got it or not, give it according to standards of clinical practice, which means they have the right to decline, and we have to rule out people that might be immunocompromised. But you can see that for both of these vaccines, by far and away, the standard of practice is to give it in the absence of overwhelming evidence from the physician or the non-physician practitioner that they should not get it now. And of course, the resident can always decline. It's our job then to make sure they understand the risks and benefits. Okay. So the question on the MDS is the resident's pneumococcal vaccine up to date? Code no if it's not up to date or cannot be determined. Code no if it's not up to date or cannot be determined. And remember that if you're coding no because it cannot be determined, we should have already given the vaccine according to the instructions we just went over. If it's not received, you state the reason, and then code yes if the pneumococcal vaccination status is up to date. So if you said it's not up to date, here are the three choices. Not eligible due to medical contraindications, offered and declined, or not offered. Okay. This portion comes from guidance to surveyors on infection control, and here's the standard of practice. The facility must develop policies and procedures to ensure that before offering the flu vaccine, each resident or their responsible party receive education on the benefits and potential side effects. Each resident is offered this vaccine October 1st through March 31st unless medically contraindicated or already vaccinated for the flu season. They always have the right to refuse. The medical record must include the documentation that the resident or the RP was provided education regarding the risk and benefits, and they either received it or did not receive it due to medical contraindications or refusal. And then for pneumococcal disease, same idea. We have to develop policies and procedures to ensure that the resident or their RP receive education and benefits. They're offered the pneumovax unless medically contraindicated or up to date. They always have the right to refuse. And the medical record has to include the same stuff that we gave them the education, we explained the risks and benefits, and they either got it or did not get it because they were medically contraindicated or they declined. And the guidance to surveyors includes the language that was in the RAI manual. A second pneumovax may be given after 5 years following the first unless medically contraindicated or refused. So the citing level of harm in the guidance to surveyors is this. You can cite at level 2, which would be D, E, or F, no actual harm, potential for more than minimal harm, it's not immediate jeopardy, if an eligible resident did not receive the vaccine but did not develop symptoms of flu. An eligible resident received 2 doses of the pneumovax due to a failure to document receipt of the first dose, but did not experience any untoward reactions, or the staff did not assess for medical contraindications prior to providing the vaccine, but there was no reaction to the vaccine. It can be cited on level 3 actual harm for these reasons. They were not eligible to receive it due to medical contraindications. We gave it to them, and they experienced a non-life-threatening reaction requiring treatment, or because of an unwarranted delay, for example, several weeks after it is available to the facility, an unwarranted delay in administering the vaccine, despite its availability, an eligible resident who has agreed to receive the influenza vaccination develops influenza. And then immediate jeopardy, somebody that's not eligible to receive it due to medical contraindications is given the vaccine and gets a life-threatening reaction, or residents who were eligible to receive them did not receive them as a result of the facility's failure to have any program for vaccinating the resident. Okay, that's coding on the MDS. Now we're going to talk about the quality measures. And the ones that VHQC is measuring are the long-stay measures for people that were assessed and appropriately given these vaccines. You can see them on Nursing Home Compare. This is just a little snapshot of how it looks there. So long-stay residents have at least 101 cumulative days in the facility. And the measures are percent of long-stay residents assessed and appropriately given the seasonal flu vaccine, and long-stay residents assessed and appropriately given the pneumovax. And these are the only measures for which higher percentages are better. And you'll see on Nursing Home Compare your organization, the state, and the nation. When I went on Nursing Home Compare in developing this presentation, this is what was there currently. Virginia, 91.65% for the flu vaccine, Maryland 94.75%, and the nation 93.6%, and pneumovax, Virginia 91.7%, Maryland 93.65%, and the nation 93.65%. Okay. So the influenza vaccination quality measure for long stay was recalculated last October 1st. So this part might be news to you. You won't see your flu vaccination percentages gradually rise over the course of the flu season we're in now, because they're not going to calculate it until the end of June. This is a big shift in what we're used to. The flu vaccination measures are calculated once a year, and the target period always coincides with the influenza season. In a normal year, when the flu season begins on October 1st and ends March 31st, that's going to be the target period. So on March 31st, they'll go in and figure out who's long stay and who's short stay, and that will be the end of the target period for the once-a-year calculation of the measure. Then it won't be calculated again until the end of the flu season next year. So it'll be calculated once to take into account everybody's vaccination status over the course of flu season. So, for a percentage of residents assessed and appropriately given the seasonal influenza vaccination, these are the people that go in the the numerator, these are the people that you get credit for being assessed and appropriately given. If the answer is yes, they received it in this facility for the flu vaccination season, or if the answer is no, but they received it outside the facility, no, but they were not eligible due to medical contraindications, or no, offered and declined. But do you see why there's not much reason that this percentage can't be approaching 100%? You get credit for everybody that you appropriately assessed that had the opportunity to get it or that got it. Okay, so here's the thing about this measure that a lot of people don't know. There are no exclusions unless you have a pediatric nursing home and the person's 175 days or younger. There are no exclusions. This measure is calculated once a year with the target period October 1st to June 30th and reports for the October 1st through March 31st influenza season. Wait a minute, June? I thought you said March. Okay. They will calculate it for people that were in the facility from October 1st to the end of March. They give you a month to get all those assessments in, and they will draw a line at the end of June and scan back looking for people that were in the facility during this year's flu season. And they will select the latest target date, that's the latest assessment reference date is the target date, and that could be an OBRA, a scheduled PPS, or a discharge assessment. So they'll look at the latest date, which is the target record, and then they'll look at the entry date in A1600 and see if they were in the facility for any portion of this year's flu season. So here's my little graphic to make sure that we all understand. So the blue boxes are the flu season, unless CMS says it's something different. They said this is the flu season for this year for purposes of calculating the quality measure. October 1st to 2015 through the end of March 2016. So at the end of June, they'll go in the system and they will scan back for the first target assessment. For example, here's a PPS 60-day. The ARD is May 1st. So the ARD is after flu season, but the resident entered during flu season, March 1st. That person will qualify for this measure. Here's a quarterly in April, but they've been in the facility for years, so they're going to look and see what it says in 00250 for flu season for them. This person discharged the last day of February. Well, it would have been the day before the last day of February in 16, but they've been in the facility for a long time, so they will qualify. And look at this one. This person discharged on the last day of October, so they were in the facility from October 1st to October 25th, which was part of flu season, so they will qualify. This is going to be calculated one time at the end of this June. So what this tells me is what the current standards of practice are, that flu vaccination cannot be, we do everybody the third week in November. And if you're not there, too bad for you. We have to be available from the beginning of flu season all the way to the end of flu season to give these vaccinations. Okay, so let's talk about what no exclusions means. The numerator for this vaccine are the people we just talked about. Everybody that got it or got it in the facility, out of the facility, medical contraindications are offered and declined. The denominator is everybody. Now notice that I don't have up here the reason not in the facility during this year's flu season. They don't need that answer to calculate this measure because the entry date's going to tell them that. If they weren't in the facility during this year's flu season, that record will not be used. Okay, so in the denominator is everybody with a qualifying record, regardless of why they didn't get it. So, not offered, inability to obtain the flu vaccine, none of the above or unknown. We want those numbers to be as little as possible. Granted, we can't affect if there's a declared shortage. However, we can affect not offered, and we can affect none of the above or unknown in most cases. The reason that's there is because there's a small percentage of people that is a real answer for. So let's just show you how that works. Forgive me. Slides are not advancing now. I need to ask Linda or one of the other presenters what you see on your screen now. What's at the top of what you see?
Judy, what I see is percentage of appropriate vaccines.
Okay, thank you. Okay, and it looks like I can't see what's on this slide. It just has blue boxes. I just want to confirm with Linda that it has blue boxes before I tell you what it said.
It does not have any, it has a blue box across the top, but it doesn't have blue boxes on the actual screen.
Okay, so you can see the illustration of no exclusion. All right. Again,
Judy, would you like to let me advance the slides? Would that help?
It looks like it would.
Okay. If you can just return that back to me, then I will do that. Okay, so what slide are you seeing?
We need to go to the one that says illustration of no exclusions.
That one?
Okay. So you can see here that if the same numbers in the numerator as the denominator, you're at 100%. And as close to 100% as possible is where we want to be. But if you have a much smaller number in the numerator than the denominator, you're not at 100%. In this particular example, you're at about 50%. That's the result of having people in the denominator that you put 9, we don't know, that you put not offered, that you put inability to obtain the vaccine. So, and also you put dashes, by the way. Dashes do not exclude you from this measure. So it's real important to offer the vaccine appropriately so that your denominator is as close to the numerator as is possible. I do understand there are clinical times when the only thing you can put is 9 not offered. Let me just give you one brief example. You explained the risks and benefits to the resident. They said they wanted it. You determined that you were going to give it to them at 2 o'clock that afternoon because they maybe had therapy, they had other activities they wanted to do, they wanted to eat lunch, and they wanted to get the vaccine. And sometime between the time you offered it and they accepted it, something happened, and now they transferred to the hospital. Okay, so that's the purpose for 9 not offered for those unusual situations. It is important to give the vaccine as close to the time as they say they want it as possible. But please be aware of the fact that even in that case, that person will be in your bottom number, in your denominator, making your percentage lower. Okay? Next slide. All right. So, do you see percentage of appropriate vaccines at the top?
Yes.
Okay. So, percentage of residents assessed and appropriately given the vaccine. For the Pneumovax, which is what you're looking at here, I apologize if that says influenza vaccine. For the Pneumovax, the choices are, is the resident's pneumococcal vaccination up to date, yes or no? So you get credit for yes or not eligible due to medical contraindications or offered and declined. So I'm not sure, I'm not aware of any valid clinical reason why this isn't 100% all the time. Any valid clinical reason. Next slide. So for this one, the Pneumovax vaccine does not, the Pneumovax QM does not work the same way the Influenza QM works. This one, you will see change. They don't do it once a year like they do the flu vaccine. So, at the end of a quarter, the denominator will be all long-stay residents with a selected target period in a rolling 3-month window. There are no exclusions for this one. So numerator, people that got it, or people that were offered and declined, or people that were medically contraindicated. Denominator is everybody. Next slide. Okay, now it's time to talk about some challenges and some best practices. So our doctor doesn't like to give them early. He gives his in the middle of November because that's how he says it works best, and that's just how he likes to do it. The days are over when we can allow that to happen. The facility is responsible for maintaining current standards of practice. One solution for this is to have facility leadership meet with your physician and go over the CDC guidelines. At cdc.gov, they have a toolbox of guidelines. And there's a particular section for long-term care providers. As a matter of fact, there's a Virginia nursing home that has a best practice listed there in the best practices for vaccinating your staff, for educating and vaccinating your staff, for education and vaccinating the residents in your facility. The facility is ultimately responsible. Your physician is likely my age or older, and they have the same prejudices I had about the flu vaccine from years past. If I'm 56, I have stories in my history as a nurse of terrible things happening 30 years ago. In fact, as we said at the beginning of this presentation, physicians aren't immune to that same type of very sincere prejudice. It's important to get out in front of it, sit down and meet with them, allay any of their fears, because they have to be on board with protecting your residents, your staff, and the public. Okay, next slide. Okay. Our doctor's fine. We give it the second week of October. We really don't have a system to ensure it's given other times. We give the Pneumovax when they come in. If they're sick at the time, we don't have to wait a follow-up to give it when the illness is resolved. These are two big things that in my experience, happen to folks. They're all proud of themselves that they gave the flu vaccine, and they're floored when a surveyor found a chart in a sample of a resident who didn't get it, and the answer is, well, they weren't here or some other reason during the week we give it. So, vaccination status has to be a robust portion of every resident's assessment or reassessment throughout the year. So, for the first one, for the flu vaccine, keep records of everybody that didn't get it. They weren't there that day or they couldn't get it because of an illness. Program it into your TAR, whether electronically or on paper, every 7 days to have the nurse, the licensed nurse, evaluate, are they back in the building now? If they are, give it now. And then you can DC the rest of the programming. Are they still ill? If you have to query the physician once every 7 days, are they still ill? Are they ready to receive the vaccine now? Are they ready to receive the vaccine now? And document that until they get the vaccine or until the physician says, this resident will not get it in this flu season because it is medically contraindicated for this entire flu season. The other big portion is new admissions or discharges. If you remember when we looked at the flu vaccine measure, if somebody discharges on the 10th of October and they didn't get the flu vaccine for this year's season, that's going to go against you in the measure when they do it at the end of June. And then for the Pneumovax, review everybody on every admission, every readmission. Pneumovax is a year-long thing. So the people, if they're too sick when they come in to get the Pneumovax, put them on every 7-day cycle, just like you did for the flu vaccine, until one of two things happens in the record. They're well enough to get it, or they're medically contraindicated, period. Next slide. We don't track the MDS responses to vaccine questions. They aren't on the CASPR report. Absolutely, this one can sneak up on you. It's on Nursing Home Compare, but you don't get a by-name roster from CASPR of who is triggering this vaccination status response. There's nothing you get from the government for the vaccine. So we have to track it manually. So first, what software do you own? Do you have an MDS software that produces reports? Do you have a software scrubber, a software logic edit and there are several kinds, that will give you information on flu vaccines? If you don't have any internal software method, require the MDS coordinator to verify each MDS for coding and report to whatever clinical manager is appropriate. So the look-back period for all items on the MDS, unless otherwise specified, is 7 days. So if the ARD is on the 7th, on the first day of the look-back, which would be the first in my case, require the MDS coordinator to go look in the chart and verify whether there are any vaccine status issues. If there are, that gives you 6 more days to get it cleared up before the end of the assessment reference period. So it's not there. It's not in the chart. We don't know. Let's give the vaccine. Are they medically contraindicated? It gives you 7 days to work all that out, so the MDS coordinator has an appropriate answer no later than the assessment reference date of that assessment. And then throughout the year, routinely audit these blocks when you have the residence care plan meeting, which should be no less than once a quarter. It's not a bad idea to audit the blocks even after flu season is over, particularly to make sure it was coded accurately. And then, of course, for Pneumovax, there's not a season. That's all year round. So anybody whose Pneumovax status is not up to date, put them on a programmed plan in your TAR, manually or electronically, to reevaluate it, unless the chart shows they won't be getting it. For example, they have a terminal illness and they won't be getting the Pneumovax for the rest of their life. Next slide. Okay, we've determined the MDS coordinator didn't know where to look and has coded many of these incorrectly or has used dashes. Usually you don't find that out unless a surveyor stumbles on it. But if you start looking and you haven't been looking before, you might find things like this. I find it all the time. So you can modify MDSs to correct the data. You can modify MDS after up to 36 months from the assessment reference date. So first, educate the MDS coordinator, tell that person where to look in the clinical records, and tell that person to let you, the manager, know if there's any issues with finding the information. And again, if they're in there on the first day of the look-back and they can't find it, that gives you 7 days to work all that out before it's coded. But if you're starting now looking for what the status is, you might run into this, so they can modify assessment. And for this flu season, now's the time to be doing that, because this flu season's measure is not going to be calculated until the end of June. So for anything you find now, you can fix now. You're not going to see it change until they calculate this flu season, because they haven't calculated this flu season yet. I understand Pneumovax doesn't have a season, so you modify that. Once they calculate a quarter for the other quality measures to include the Pneumovax, they don't go back and recalculate that quarter, but you can get the MDS correct for survey purposes, and it'll be correct going into the next quarter if you've educated the MDS coordinator and set up a program to ensure that they are instructed to work out any problems earlier in the look-back so that the answer will be correct on the assessment no later than the assessment reference date. Okay, next slide. We can't keep the vials on hand. They expire and it costs money for no reason. This might have been from my generation of nursing more than today, but first off, require the pharmacy to fill the orders promptly and notify the nursing manager, I said the DON here, if they're not able to get the vaccine. There's no reason to keep vials on hand all the time if your pharmacy can deliver in a day or two. But it is absolutely true that you may use one dose and have to throw the rest of it away, and we're just going to have to budget accordingly for that. And your pharmacy can give you statistics to the penny on how much you spend on pneumovaccines, how much you spend on flu vaccines, to give you an idea of what to budget throughout the year for pneumovax and then through the flu season, through the flu vaccination season for the flu vaccine. Okay, next slide. Okay, just as a recap before we open it up for questions and comments, I'd love to hear best practices. If you got this under control and this is not a problem at your facility, share with other people what you're doing, and then any questions or clarifications or comments they ask. So as a recap, we have to make vaccine status and delivery a way of life at your center. Always know who hasn't been vaccinated and why and where they are in the plan to get vaccinated. If there's an acute illness or an absence, as the reason why they haven't been vaccinated. And don't forget to follow up on declined vaccines. It's absolutely true you'll get credit for them in the numerator, but we need to make sure they've been given quality education and current standards of practice and make sure they're not declining due to any beliefs they have that aren't accurate about what the vaccine may or may not do to them. And then always follow up on medical contraindications until the IDT, led by the physician, is very clear that this person is not going to get it for the remainder of their life. And then consider the care planning considerations for them. Next slide. Okay, I am turning it back over to Linda, and I appreciate her help with the slide.
Thank you, Judy. I think that maybe when we were having issues with the slides advancing, we may have missed slides 13 and 14. So if you don't mind, if I go back to those, would you mind reviewing those?
Be happy. We did in fact miss them.
Okay, we will go back. There we go. Do you see that?
Okay. So these are coding instructions for the flu vaccine. I tried to kind of fold it in, but just to be very clear, the flu vaccine is an 00250A, and the instructions are, you code no if they did not receive it in this facility for this year's vaccination season. We had a discussion of that, and if it's not received, state why, which will be on the next slide, and then code yes if they did receive the vaccination in the facility for this year's influenza vaccination season. Next slide. So these are all the reasons possible for saying no, they did not get it in this facility for this year's vaccination season. Number one, they were not in the facility during this year's vaccination season. And remember, those people are not even considered for the vaccination measure, but it's important for your practice to know this information. So the other choices are they received it outside the facility, they were not eligible due to medical contraindication, they offered and declined, and that's one we need to follow up on to make sure. It's important that the person giving them the risks and benefits understand enough about it to be able to say, how you feel about this, I'm wondering why you don't want it, to see if there's any illogical reason that comes up to try to give them good information. And then 5 is not offered, 6 is inability to obtain the vaccine due to a declared shortage, and then 9 is none of the above. So as we said, a dash would never be appropriate in this box.
Okay, thank you, Judy. I appreciate you taking the time to go back. Wonderful information, very helpful, very valuable information on MDS coding, appropriate assessment, delivery of vaccines, and the challenges in monitoring and delivering vaccines in the nursing facilities. So, Judy, thank you very much. This information is very helpful and very valuable. At this time, we'll look and see if we have any questions in chat. Okay. looks like there's a few questions about receiving copies of the slides, and of course the webinar was recorded, and so that will be available on our online community in several days. Okay, at this time we will take questions from the audience, but first, Emily, if you would post the evaluation questions for the audience, and they will appear on the right-hand side of your screen, and they're there now. So, Wes, would you please open the line for questions and remind the audience of how to ask a question?
Certainly, the floor is open to your questions. If you have a question or comment, please press 7 on your telephone keypad. Okay, at this time, there are no questions over the telephone.
Okay, thank you, Wes. And if there are no questions, we will conclude the webinar. And we want to thank each of you for participating in today's webinar, and a special thank you to Judy Wilhite-Brandt for presenting. Please take a moment to complete the evaluation that is showing on the right-hand side of your screen before leaving.
And we also noticed that it seems like folks don't have a copy of the presentation from today, so we will be sure to not only post the recording onto that NHIN online community, but to also post slides that can be printed. So again, as mentioned in chat, you can join the NHIN online community by visiting the website that is posted, and we'll post that again before we close up today. But thank you so much.
Thank you, everyone, and have a great afternoon.
Thank you. To conclude today's teleconference, we appreciate your participation. You may now disconnect your line at this time.